So I'm Julian Mitten. Great. Um, I am an internist and addiction medicine specialist, and I've had the opportunity to practice in a variety of clinical settings and in a community health center, in a large academic referral center, as well as some time with the Indian Health Service in rural parts of the country. So really pride myself in having had the chance to practice in a variety of clinical settings. And I transitioned from clinical practice a little over 5 years ago, first to research and then to healthcare administration and leadership. I completed some postdoctoral training in health services research and implementation science. And most recently served on the population health team at Common Spirit Health, where I oversaw the implementation of a collaborative care program in primary care practice. I moved from Common Spirit and now medical director at Zero Overdose, which is a fast-growing national nonprofit focused on increasing access to evidence-based harm reduction tools. And I also continue to work as a healthcare consultant on behavioral health and integration and primary care redesign. And thrilled to be joined by my mentor and dear friend, Verna Little. So I'll pass it off to you, Dr. Little, for an introduction.
Great. So excited to be here and get an opportunity. I always feel when we get a chance to present together, it's so much fun because we can just chat and both love to. I know for those of you who know me, I could talk about collaborative care all day. So so why don't we go ahead to the next slide? Very excited to do this, particularly for the medical directors. So I'm going to kick it back. Actually, Julian, why don't you start us off with the learning objectives and then I'll pick up from there.
Perfect. Great. So goals of our session today, learning objective number one, describe the collaborative care model and its utility in general medical practice. Number two, identify ways to successfully engage colleagues and providers, peers in collaborative care using evidence, learning, and evaluation. And then finally, three, devise an evaluation strategy that includes measurements from key health outcomes, process, experiential, and financial categories. So we're going to get us started with a discussion of what medical directors absolutely need to know to be successful in the collaborative care space. That includes a review of the characteristics and principles of collaborative care. And I know no one better than Verna who could facilitate that. We're going to take a pause. I'm going to share my experience of launching a program as well as some lessons learned from, again, a pilot evolving into a multi-state collaborative care program. Discuss the importance of taking a population health approach and ways of generating volume, or more likely matching need with supply. We'll discuss some of the characteristics of a successful leader and partner in the collaborative care space, and I'm hoping we'll be able to pause and facilitate some discussion across this group, and then finally wrap it up with a discussion of evaluation plan and financial reporting considerations. So plenty to get through in the next 45 to 50 minutes. So let me pass it back to you, Verna, for our next slide on what directors need to know.
Great. So I wanted to kind of put in one place just to really kick us off some lessons learned and some things that we've heard from medical directors. And so the first thing is that it's really important to understand what collaborative care is. I've known organizations that have been implementing collaborative care for 10 years and had recently had an organization in Michigan, actually, and one of the things that happened was the medical leadership sat down and actually went through collaborative care, understood it, had a conversation around it, and sort of really began to think about how it would look in their practice. And once that happened, it was like night and day. And the leadership will say, it really just didn't take off because we just didn't really understand what it was. And so I really encourage you to really do a deep dive and understand what collaborative care is. It is a primary care initiative. I love my colleagues who are behavioral health leaders. I love you dearly. I've known some people on the call for many years. I see Tanya smiling, right? More years than we want to know. But the reality is that this is a primary care initiative. And whenever an organization comes to me and says, we want to do collaborative care, I worry if the primary care leadership and the medical director is not at the table. And most of the time, that is not a successful implementation. And so it is a primary care initiative. And actually, the collaborative care codes themselves require primary care engagement and involvement. And so really important to know. And it only works if the primary care understands the team involvement and the communication and the role of the people on the collaborative care team. The other piece is to really understand the population approach. And so oftentimes we talk about our population of patients with diabetes and how many different kinds of services. We might have dietitians, we have a diabetes registry, we have, some of these diabetes educators, and lots of different touches for people. And so this is a population health approach for your entire population of patients with depression or anxiety. So everyone with depression or anxiety should have a care plan. You should know what their PHQs or GAD scores are. It's kind of like being a diabetic and not knowing what their A1C is, right? You should really have that for everybody. And one of the big often mistakes is that we think that a collaborative care initiative is going to get populated by just referrals from primary care. That actually couldn't be farther from the truth. It has to be a population health approach. I tell organizations and medical leaders, pick at least 2 population health approaches. Are you going to have a best practice alert in your EMR? Are you going to have, anytime there's a prescription written, that there's a referral to collaborative care? Like, what are some of the population health pieces that you're going to actually put into place? And you have to do measures. I went into an organization recently that's been doing collaborative care for about 6 years. And I talked to the providers and they wanted to kind of do a reboot. And I asked them to see their outcomes. And they didn't actually know that there were outcome measures for depression or anxiety. And Dr. Mitten's going to talk about that. But they didn't actually know we were looking for a 50% or 10-point reduction in depression or anxiety. Like, that had never been communicated. And so really make sure that everybody understands what the outcome measures are and that you understand, and also that it can be financially sustainable. It's not going to be financially sustainable unless there's enough people, right, that you're caring for, but that it can actually be financially sustainable. So a couple of little words of wisdom there that we've learned over time. And it is really important to understand, collaborative care itself is evidence-based. And we have learned a lot about how to care for behavioral health conditions. Years ago, we cared for HIV or cancer very differently, right? So in behavioral health, we've learned also. And what we've learned is that when you have a system in place, you actually have way better outcomes. And collaborative care now is evidence-based, supported by over 100 randomized controlled trials that originally started with one that had 1,800 patients and 400 providers, which was 20 years ago at this point. And so that collaborative care model embraces the evidence-based practices that we know work for depression and anxiety: cognitive, behavioral, motivational, interviewing, problem-solving treatment, behavioral activation. You can go ahead. But that it actually looks very different in that, because it's that monthly case rate, that behavioral health care manager that gets added to the team, which can be a master's level clinician, although CMS doesn't require licensure, but is generally a master's level behavioral health clinician. Because of that monthly case rate, they could talk to the patient every day or every other day. They communicate with the provider so that they know what's going on. And then they meet with that psychiatric consultant. That psychiatric consultant, again, doesn't see patients, doesn't prescribe medications, but really makes recommendations to that principal provider. And the reason that we have a registry so core to collaborative care so that we know if people are getting better or getting worse so that we can prioritize them for psychiatric consultation and really manage our entire population of patients. And generally, a behavioral health care manager has a population of anywhere from 75 to 90 patients as part of a caseload. And that is because it looks very different, right? If I was providing therapy and I was seeing everybody weekly, that I would have a different caseload. But this actually looks very different. Go ahead. And one of the things that it's important for providers to understand is that even though collaborative care has an umbrella and it's evidence-based, again, we use all of the evidence-based treatments that we know work underneath that umbrella, and we are very treat to target. We are looking for that 50% or 10-point reduction in 90 days. We're looking to get people below 10. We're ultimately looking to get them below 5 and being accountable for our
It
entire
just felt
population.
like I was
Oh,
super old, right?
somebody wants to mute if you're not speaking. So go ahead. And I think, for so many years, providers had only had one choice, like we send someone to counseling and they get that or they get nothing. And so collaborative care, the most important thing to really understand about a collaborative care is the treatment choices. And so a patient can be in one choice or all of the choices, and they can change from week to week. So the first, there is talk treatment or therapy. There's a big misconception that collaborative care doesn't provide therapy. That's actually not true. Collaborative care uses all of the same evidence-based practices, and people can be in talk treatment or therapy. It doesn't need to be at a 45-minute a week cadence. There's no research to support that anyhow, but it can switch. It can be from week to week. So I could say, Sujina, it looks like you have a lot going on. Maybe we could set up a time to talk a little bit more next week. So Sujina could be in talk treatment for just that week. Behavioral activation, the goal setting. What's something you could do today or tomorrow to be less sad? To me, this is the most effective treatment choice in collaborative care. Medication adherence, helping people around medications. People could just get support around medications. On the flip side, they don't have to be on medications to be in collaborative care, which is also another misconception. And then symptom monitoring. Sometimes people aren't engaging in care and say, it's really important for your provider to know how well you're doing. I'd like to give you a call once or twice a month, ask you some questions, right? So just that symptom monitoring. So I can be in all of these. I can be in one of them, and it can change from week to week. But it's really important to understand that all of these treatment choices are what's available to patients and that they can pick from under collaborative care. So, Dr. Mitten, I'm going to turn it back over to you.
Perfect. Thank you, Dr. Liddell. Really appreciate that. So moving from a more theoretical discussion of collaborative care, I wanted to ground us a little bit and share with you all briefly my experience in launching a collaborative care program in California. I came into that leadership role a few years ago with an understanding of the rich evidence base, as well as a hands-on appreciation of the value of collaborative care from my own clinical practice. So I got to see in a firsthand basis how collaborative care increased access for my patients, improved outcomes, and really bolstered my clinic with a broad supportive team. There was some work that was being done before I joined CommonSpirit, which is one of the nation's largest healthcare systems, quite a clinical presence in both the inpatient and outpatient setting on the West Coast. But when I did join the team, there was a clear interest in supporting many of our, for lack of a better word, burnt out primary care teams, especially in some of the more traditionally underserved parts of the state. And data that was collected through a series of interviews that I helped facilitate really showed that there was a specific request coming from our PCPs for assistance in their ability to manage and have their patients engage in compassionate evidence-based behavioral health care. At that time, this was 2019, 2020. At the start of the public health emergency, there was a recognition that the mental health crisis that we all face on a daily basis was only being compounded by the pandemic at that time. And there was a specific request for assistance in increasing access to effective behavioral health care. But one of my favorite direct quotes from those interviews was from a primary care champion in the Central Valley, and they asked for, quote, nothing fancy, no new apps or login, please. What they were looking for was a solution that aligned with their clinical workflows, and that really supported their primary medical home approach to care. They were looking for an evidence-based solution and an ease around scaling and expansion, though with a recognition that there are a lot of challenges in how to adequately staff up, especially in the behavioral healthcare space. And finally, there was a desire that this solution that we were building towards, working towards, would help align with some of the larger business health equity goals in assuring equitable access to behavioral health care, especially in engaging some of our traditionally marginalized populations. So I'm curious if any of this resonates with you. So please drop some comments in the chat. Add any particular values on BHI that you think that this list might have missed. But given all the feedback that we gathered, again, and my real passion for and commitment to the collaborative care model, we decided to use the collaborative care model in a small pilot, first working with about a half dozen providers in the Central Valley of California, launching in late 2020, and setting about a 6-month pilot window with very clear expectations around how we would define a successful pilot, including key process as well as health outcomes measures. Given some of the challenges around staffing within the behavioral healthcare space, as well as a desire to eventually scale up, with a successful pilot, the decision was to turn to an external vendor to provide the collaborative care rather than developing some of our own internal functions. But that's a decision I think is one that is unique to the particular needs and the particular capacities of your practice site. After the pilot, we were able to scale very quickly to move into several new regions within the state, and after 2 years evolved into a multi-state initiative that touched more than 5,000 patients, engaged about 250 referring providers, and with health outcomes at or above national benchmark data. So really proud of that work. But all that makes it sound easy, but it was not. It was a lot of work with some clear challenges and opportunities for improvement. And I just wanted to share some of those with you here. So some of the early successes that we were able to point to, we had really great patient engagement rates, as well as excellent patient and provider satisfaction. We were able to gather some of this data and share that with our leadership. And then, as I mentioned, we're able to point to clinical outcomes at or above national benchmark data. So as Dr. Little alluded to earlier, during our pilot phase, we were able to point to a 10-point or 50% reduction in either the PHQ or the GAD-7 assessment tools of about 65+% of the patients engaged in care. And then really proud of our work to engage a diverse set of patients. One of the data points that I'm most proud of during that period is that during the pilot phase of taking all of the patients that were engaged in collaborative care and clearly had a behavioral health care need, more than 3/4 of them shared with us that they had never had the chance to engage in mental health care before. So clearly this is a program that was expanding access to evidence-based care, and really making a clinical impact. Now, some of the challenges that we faced, a lot of early payer resistance. This was from 2+ years ago when the collaborative care codes were less common, or many plans were less aware of the collaborative care model and the specific codes that we'll get into shortly. We were in the middle of an EHR transition as well, so there were issues around aligning IT to really support the collaborative care model. Not only did we face external questions around billing, but also internal issues too. Why are these primary care codes for mental health service that's being rendered? Why is the primary care doctor dropping the codes when the care is being managed by a team different, is how they would define it from the primary medical home. So a lot of work and effort to educate our billing and internal leadership teams that they understood the unique aspects of the collaborative care model and what the intentions were behind the evidence-based approach. And then
Dr.
finally,
sorry
yes.
to interrupt. There's a question in the chat. John is asking, have you all been able to bill in FQHCs?
Yes. Yep. And we are going to get to some more specifics on billing, but I'm happy to sort of circle back to that question, but also curious, Dr. Little, I imagine in your work you've had the chance to partner with some FQs.
Absolutely. So there's a couple of things that really matter for the FQHC. So certainly Medicare and commercial in any setting include the FQHCs you can bill. FQHCs, you need to use a different code. It's the G code for your Medicare patients. There's about 30 states now that have put the codes onto the Medicaid fee schedule. Unfortunately, they've been a little all over the map in terms of how they've done that for the FQHCs. So if you want to reach out to us, then we can give you the specifics for your state and help you with the billing.
Yep, happy to. And then finally, one of the last challenges that we faced was some misalignment between what the providers were expecting and what the evidence base speaks to in collaborative care. In many of the settings that we moved into that had just such a large need around access to behavioral health care, there was an assumption that the collaborative care model would be able to address all of those concerns, including providing support for patients with active disease symptoms and or serious mental illness. So with that challenge, we recognized that we needed to invest in early work in making sure that we align what our providers were expecting with what the collaborative care model really speaks to and what the internal and external capacity is. So finally, taking all that into mind, just some core lessons learned here. Number one, the importance of identifying early clinical operations, business, and regulatory buy-in. So making sure that you have leaders at the table from each of those groups from the get-go. Number two, as I mentioned just now, making sure that there's alignment between what your colleagues and peers expect and what the model and evidence really speaks to around collaborative care. Number three, think early about sustainability, set goals around volume, scale, and also set some sort of very clear expectations around financial goals and reporting expectations. Four, have some very clear plans around how you're going to rigorously evaluate and capture some of the care experiences across the cascade of care. And then finally, this is something that Dr. Little alluded to, really think about ways that you can generate volume or more appropriately tap into a very clear underlying need for behavioral health care by thinking through more of a population health approach, or expanding the ways in which patients can be referred rather than leaning only on referrals at the point of care. So on that point about population health, just the recognition from data. This is data, recent data from the Kaiser Family Foundation that speaks to the prevalence of anxiety and or depressive disorder symptoms in the general population. And what we're seeing, and I don't think would be surprising for anyone in this group, is that up to a third of the general population is experiencing symptoms that would warrant engagement within the collaborative care framework. And with that percentage being even higher, approaching potentially 50% among some of the younger or adolescent populations. So we clearly know that the need is there. And again, during our pilots, coming back to the examples that I worked through, our expected volumes were definitely not as high as we observed volumes that are not as high as what we expected. And we think that was because during our pilot, we really leaned on that point of care referral base, rather than turning really quickly to taking more of a population health approach. This is an case example that Dr. Little shared, an example of an 8 FTE group that had about 54 patients engaged in behavioral health treatment. But they generated a population health pursuit list that pulled a list of all patients being prescribed either an antidepressant or an anxiolytic, and yielded a list of approximately 2,000 patients. So much more than the simply 54 who are actively engaged in care. The practice took on a concentrated effort to touch and engage each of those patients to administer either the PHQ-9 or GAD-7 assessment tool. And they noted that several of those patients were scoring very high. They were able to engage them in collaborative care, place them in a care plan, and provide them with some relapse prevention. So really, again, speaking to the value of a population health approach. In generating those pursuit lists, some of the inclusion criteria that you might want to consider including would be either a current or past diagnosis of anxiety and or depression, pulling data from both the problem list as well as coding lists, past or current anxiolytic or antidepressive prescriptions. You could also lean on PHQ-9 and our GAD-7 scores. You might also want to consider including on that list patients with a co-occurring substance use disorder, because there's a lot of overlap and comorbid presentation. So these are all considerations in ways that you can generate pursuit lists and be able to connect patients who clearly have a need with one of the collaborative care champions and team members. So finally, once you set yourself up for success with being able to generate volume and tapping into demand, it's a good time to then also think about how you're setting yourself up for success from a sustainability perspective. So as I mentioned, it's worth setting goal rates across the arc of care, from screening to collaborative care, referral, engagement in care, and then graduation from the service. So each of those key steps, and really set some clear goals around patient rates that you would want to engage. There are unique finances that are unique to the collaborative care model. There are codes that I'll just review briefly here. So there's the 99492 code, which is used to bill for the first 70 minutes of the first initial month of collaborative care, 99493, which is the first 60 minutes for any subsequent month, 99494, which is each additional 30 minutes, and can be used in conjunction with either the 492 or the 493 code. There's that G code that we mentioned, so the G2214, which is used to bill for the first 30 minutes in the first month of care, and that's a code that is specific to Medicare, and as we mentioned, would be of particular use within the FQHC setting. And then finally, there's this sort of orphan code, the 99484, which is a more general behavioral health integration care management service code that looks for cumulatively about 20 minutes of care provided. The most recent data I have on the fee schedules are from 2020. So please check me, Verna, if these are old, but looking at Medicare reimbursement rates. So for the 492, looking at about $162, 493 looking at about 130 plus, 494 $67, and then the 484 about $48 to $49 for that code. Again, these are Medicare goals, so rates on the Medicaid and or MA and commercial plans will vary, either above or below what those rates are set. And then finally, again, when you build out that financial model, you're going to, again, want to think about ways, as I mentioned, that you're going to try to generate volume. As I mentioned, there's the population health approach that can be taken. There's the referrals at the point of care. You could think about taking more of a team-based huddle approach, maybe on the weekly basis, bringing members of the multidisciplinary care team, looking at a list of patients that are being seen within the next week or two, and consider ones that would benefit from a referral to collaborative care. And then finally, I think the most interesting ways is to try to integrate clinical decision aids within either the EHR or pre-existing workflows to nudge members of the team to consider a referral to collaborative care when it is appropriate. So really thinking about ways that you can leverage IT or the EHR to help facilitate referral to this evidence-based service. So all considerations here on how to generate volume, tap into the underlying clinical need, and set yourself up for success from a financial perspective. So with all that being said, as you set yourself up for success, there's going to be variability in the ways that you engage your colleagues and peers. I think some are going to be super ecstatic about the collaborative care, and then some are going to be more cautious. This is a newer approach that's different from traditional behavioral health. There will undoubtedly be some questions about the referring provider still being the rendering, supervising, and or the prescriber. And some of those questions are all valid, and I think are ones that you should expect and prepare for. Ways to successfully engage colleagues, I think really trying to identify local champions early. Who are those local champions within the clinical setting that you can lean on to help address questions or concerns from their peers, and really empower them as an effective implementer at the local level. and try to emphasize and model multidisciplinary care yourself. Think about bringing in a diversity of perspectives and experiences as you build out your own leadership team. Set expectations, as I mentioned, about the collaborative care model and try to compare it and contrast it with traditional behavioral health care. You may want to try using some case-based learning and orientation and being able to access your peers and also build a little bit of an evidence-based learning process. Many within the healthcare space were sort of taught and think through case-based approaches to care. So being able to orient them through case-based learning may be very effective in answering questions and engaging care. That was an experience that we found as we looked to scale up into new settings, especially as we look to, again, align expectations with the collaborative care evidence base. Also, a scalar approach that the team and I found very effective is trying to marry evidence with patient experiences or narrative. So trying to contextualize the evidence base out there and bring it a little bit closer to home so that your peers can begin to think through potential patients that might value from referral to collaborative care, or what the program means in terms of alignment with current clinical workflows. And then finally, that mention around leaning on IT and EHR systems to really be supportive to your peers at the point of care, with the recognition that we want to avoid alert fatigue, but really think about how to encourage them to consider referral to collaborative care in the right appropriate setting. So finally, with that all said, I wanted to pause. Clearly, we have a lot of experience and expertise in this virtual room. Would love to invite folks to come off of mute and or drop some comments in the chat about what are some characteristics of a successful collaborative care medical leader. To get us started, I just wanted to emphasize the importance of modeling and emphasizing multidisciplinary team-based care in who you engage, who leads, who communicates around the collaborative care approach. Yes, peers connect well with peers, but I think there's also a way to try to foster more collaboration through learning communities and case-based orientation that leans on other members of the multidisciplinary care team. So that's one, I think, characteristic that comes to mind, and I encourage, again, others to chime in here. But also, I just wanted to turn to Verna. I'm curious what you think. You have a lot of experience working with and partnering with a variety of medical leadership. What have been some successful or positive characteristics that come to mind?
I think the good collaborators, that are really engaged in the psychiatric consultation, and the ones that also were really engaged with the behavioral health care managers. And I always think about it really trying to sort of wrap a warm fuzzy blanket around the primary care providers, and those who really engage with those team members really get that kind of support, and they can see huge differences in the patients. I mean, when you think about reducing someone's symptoms 50%, like how much that not only changes their day-to-day, but how they care for themselves and their chronic illnesses, how differently they eat, how much better they engage in care and exercise. And so I think the providers who really sort of understand that piece are really fun to work with in collaborative care. And I
Very
think
true.
I'm going to add one more piece in that they really have to drive some baseline prescribing as well. That there needs to be some consistency that says, we prescribe first and second line meds, and then we sort of go with what people are comfortable with. But at the very basic, I talked to a practice the other day and they were like, we're not interested in prescribing meds. And I said, well, collaborative care is never going to work for you, but I'm not even sure that's going to work for you in primary care. So there has to be some consensus and some standardized, guidance.
That's great. Yeah, that's a really great point. I think that was the challenge. Again, thinking back over my experience that we faced early on is, some uncertainty about this fact that the referring PCP still maintains that basic prescribing function, and sort of drawing the connections around what the evidence base speaks to, but also having consistency across the practice around what the referring PCP would appropriately prescribe. And there's value in the collaborative care model in that it connects them with a psychiatric consultant who can coach them through that process. But there really needs to be some modeling and standardization around the PCP still being that primary prescriber.
Yeah.
Any other thoughts here around characteristics of successful medical leadership?
I know we've got some other folks on the phone who do work. I see Danny on the phone, and Danny actually, I'm calling her out big time. She had a role in this implementation as well. So
Sure.
maybe, Danny, I'm going to call you out if you're on the line still.
Wow, Verna, way to put me on the spot.
Right under the bus, my dear.
Right. What was that question again?
Characteristics of a successful collaborative care medical leader. So we've talked a little bit about modeling multidisciplinary care, standardizations around prescription practices, finding those local enthusiastic champions who can really speak to the collaborative care model. Anything else to add to that list?
I think that, speaking of that Bakersfield pilot that you mentioned earlier, Dr. Midden, a lot of the work was really on the ground, really getting to know and understand the needs of the providers. And it really helped to have someone like you on the team to speak doctor speak, and to give me insight on what providers were looking for, so that we could get to know them and understand what their needs were too. Really focusing on that quadruple aim. It's not just only about the patient care, it's also about reducing that burnout and what the providers will benefit. And having those providers be able to encourage these programs and share the successes that they've had with the program was really helpful.
So a medical leader that sort of brokered collaborative care and the care manager and the medical providers, and that landscape.
Exactly. And what I found was, once we got those medical providers that were initially resistant and they got on board, it seemed like all other providers would jump on the bus and follow suit as well. So being able to broker those relationships and really leverage that was really helped with the success of the program.
Thank you. And thank you for allowing us to call you out.
Yes, thanks, Danny. And I think what you shared is really aligned with what Dr. Thomas just dropped in the chat as well. Thinking about the value of peer-based connection, education, and support. It's sort of as a foundational intervention to try to build enthusiasm and interest in the collaborative care work.
Hi, Julian. It's Jen Thomas. Could I ask you a follow-up question about your leadership experience?
Please, thank you.
Yeah, great. did you have any resistance from your health system to set aside time to lead this work from the medical director side of things? In my experience, it's been a great, yeah, we believe in collaborative care, but ultimately, if you're the one driving the bus, then you're pulled into more meetings and you're pulled into more, hey, talk with this PCP who's a late adopter.
Yeah.
Eventually, I think sometimes we as the PCP champion get spread pretty thin to not only maintain our clinical practice, but then also be the champion for our peers, and without designated FTE or protected time, it can be an overwhelming task. And I think that's one thing we'll probably see with PCP champions over time is like, hey, this is a role that's designated, but it's probably going to be something you have to advocate for the value of that time if you're not just turning out RVUs in your primary care practice.
I'm going to actually add to that, because one of the things we found is that the medical leadership also needed to set time aside to meet with the providers around prescribing and do some education and some follow-up.
Yes.
So I'm going to add that to your list of tasks and then turn it
Correct.
over to Dr. Mitten.
Yeah, really great question and call out. Thank you for that. So absolutely faced some resistance and hesitancy to support that sort of protective leadership time. We were ultimately able to facilitate that through grant-based support around piloting and implementation. And then once we were sort of able to show the value associated with having some protective time as well as building out a multidisciplinary technical assistance team, the health system was able to find ways to continue to support that. So I think I respond to your question with a recognition that I think that it's a challenge. It is a real challenge that I think many will face. It is really hard to sort of find that time within the RVU systems that we're all used to. Trying to carve it out with some time, I think is incredibly important. Turning on some other sources of funding might be the way to make that happen, whether that's grant-based or leaning on training dollars, whatever that might be. And then once you're able to really speak to and show the value, hoping that there will be some sort of recognition that will include that protected time as a line item. The other thought that comes to mind is also not taking all the onus on yourself and thinking about how to spread it and share it across that multidisciplinary team. Finding other local champions that you can lean on, that you can turn that you can turn to, so that the buck doesn't always stop with you, and it becoming unreasonable burden or expectation. So those are my thoughts. Yeah,
that's excellent. Yeah, Werner, I'd be curious your comments on like RVUs and helping other organizations. Is there like a formula? I feel like our CMO comes back to like, well, we would figure out what your time is worth to do this leadership role in collaborative care, but we don't know how to quantify that. Are there calculations? Is that something that can be shown?
I think not for leadership roles. We're just not sort of down that path. And organizations, if you've helped one organization with RVUs, you've helped one organization with RVUs.
Yeah.
But I think there are some organizations that are just carving this out of the RVUs completely, and others that are attaching for the 492 a little bit higher, or just the only one, and then others who are doing higher 492 and then for ongoing 493s. And I think if you have to carve them into the RVUs, then that's kind of the way to do it, because then you're not only incentivizing the referral, but sort of the ongoing engagement. But yeah, and the CMS attached RVUs, most organizations don't think those are accurate or helpful, and so have kind of gone different paths.
Okay, thank you. That's great. Daniela, I love your comments on many PCP champions. In my experience, that was the only thing that I think helped us sustain, is that in each practice site, we had to say, okay, who's our most engaged provider? Can we get them to talk to the late adopters? we formed like a little work group where all the PCPs that did collaborative care jump on a lunch and learn and just kind of talk over what it's like to do collaborative care. Maybe we do some of that didactic stuff like Verna was saying about prescribing, just to kind of learn together. And I think that has been our most impactful thing, is just kind of being an influencer, if you will, right? Like of your peers, like this is something we could do together. It's enjoyable. It actually helps us feel less burnt out to work on a team and have some other new faces in the clinic. Having a care manager that's, Baker Health background is fun. It's neat to learn from them and they learn from you. And I think being that ambassador to kind of teach others to be the PCP champion is phenomenal. So yes, I'd say get out there and empower your other like-minded people to be that little spark in their clinic and
Absolutely.
get together and chat.
And I love that because it accounts for turnover too, right? How many times have we seen a provider leave or get reassigned to another clinic and there goes your pilot or there goes your project. So at least you have a built-in backup.
For sure, absolutely.
Yeah, no, thank you for that. And I couldn't have said it any better to, finding ways to sort of share in that responsibility across the team and build that coalition. Just one last point around finding data on implementation costs, a really hard one to answer. There was a report recently released by the Meadows Policy Institute a few months ago, which tried to put some data around expectations, and financial costs associated with implementation. I will try to find the source and drop it in the chat, but I've found that to be a particular helpful tool in giving you some ranges around costs from an implementation perspective in discussions with senior leadership. So thank you for that, Dr. Little. So just with the recognition that we only have a few more minutes here, just wanted to circle back around a recommendation that you have sort of very clear expectations around how you're going to capture the success of your program and track it over time. And I just wanted to share with you all, this is an interesting study that came out of the University of Pennsylvania that spoke to some of the costs associated with the collaborative care approach. And what the study did show that a modest spending on integrated mental health services in the primary care setting, and this was collaborative care, they did use the new collaborative care billing codes, did not increase overall healthcare costs. So what you see here in the study that matched 825 patients receiving collaborative care through a propensity score matching process with controls, that they did expectedly show an increase in collaborative care costs. That's that $34 line there, and that was a statistically significant difference. This is what we would expect, but there was no increase in overall cost of care. In fact, there was a trend towards a reduction in care, and that's the negative $29 at the top of the chart here. But that was not statistically different, so they were not able to comment on the reduction in cost, but there was no differences around cost. So I think what this really speaks to is that there is value in using collaborative care around increasing access, that yes, there are associated costs with the collaborative care service, but it really does not have an impact on overall costs, with trends actually speaking to and showing cost savings. And finally, just in the last minute or so, we have here what to measure and how to capture your success. Danny, this is going to be a slide that you've seen recently. So thinking about pulling measures from each of these groups, really being able to capture the holistic nature in which your program is having an impact on patient care. So including measures from health outcomes key process measures across the arc or cascade of care, as I mentioned earlier, trying to capture patient experiences as well as the experiences of your peers and other members of the team. And then again, being able to document and report on direct and indirect costs with a goal of eventually being able to really speak to the return on investment in this sort of implementation work. So this is not at all an exhaustive list, but one that you could consider to pull some factors from, and really making sure that the reporting expectations are aligned with what your program wants to show, what is expected from your institution and your leadership. And that actually brings us, I think, to the conclusion here with a minute or so to spare. So thank you all for your time, but happy to hang around a little longer if folks have any questions, and or please feel free to reach out to myself and our Dr. Little, and we'd be happy to try to follow up on any sort of questions that you have.
Well, thank you, everyone. I loved all the in the chat and all of the unmuting and the conversations, and great to see some smiling faces. Dr. Mitten, thank you so much. It's always helpful to hear from somebody who's actually done it. Like, I actually did this, and this is what I learned from it. So thank you so much for sharing all of the insights. I know we're at time. This slides will be shared as well as the recording. We appreciate all of you. Again, Dr. Mitten, thank you. And the message for the day that we're all going to go out on is be a spark.
I love that. Yes.
I love it. That's the word, the message for the day. So all of us go out and be sparks, and have a wonderful day.
Thank you all. Take care.
Bye.
Thank you.
Thank you, everyone.